to be elected to that role. Then we will hear from Sarah Stinton, who is the Dean and Patricia M. Davidson Health Equity and Social Justice Endowed Professor at the Johns Hopkins School of Nursing. She holds a joint appointment in the Department of Health Policy and Management at the Johns Hopkins Bloomberg School of Public Health and the Johns Hopkins School of Medicine. Her main research strands are improving health equity among older adults, aging in community, the effects of financial strain on health, and structural racial discrimination and resilience. Lastly, we will hear from Shannon Zank, Director of the National Institute of Nursing Research. With a background in nursing and public health, Dr. Zank's research is centered on environmental injustice and health disparities. Since becoming the director of NINR, Dr. Zank has led the development of the Institute's new strategic plan with a bold focus on social determinants of health and health equity, and serves as the co-chair of several NIH-wide efforts, including the Social Determinants of Health Research Coordinating Committee, COMPASS, IMPROVE, and the Climate Change and Health Initiative. I'm looking forward to all of your presentations and our conversations. Let us start with Dr. Flynn. Dr. Flynn?
Okay. I didn't. All right, sorry for the technical delay here. Are we good to go? All right. All right, thank you. It's not advancing. Okay, great. So I'm going to start really quickly by answering the question, why should we care if the nursing workforce is in a state of crisis? What's the connection between nursing and the public's health? And this little picture here is really taken in New York City around the time that the term public health nursing was first coined. There are decades of research, and in fact, when I search in the Rutgers Library database, there are about 1,500 studies that have shown that there is definitely a quantitative impact of nurse staffing levels on patient outcomes and patient adverse events. So I'm going to share with you just the very first meta-analysis that was done back in 2007, published in Medical Care. Robert Kane is a health services research, and he found a significant association between increased levels of RN staffing and lower odds of hospital-related mortality. The one in pink was published in 2010 in Health Services Research. I was actually co-investigator on this study of 604 hospitals in 3 states. And what we found was that if the other 2 states, Pennsylvania and New Jersey, would adopt the California legislated staffing ratios, we could reduce post-surgical mortality in New Jersey by 7%. And then lastly, one that was just published in 2021, 52,000 patients admitted to the hospital for sepsis, significant relationship between lower RN staffing levels and higher odds of inpatient mortality. So what is going on with the nursing workforce today is the result of, unfortunately, a perfect storm. It's the impact of the pandemic, which I'll talk about in a minute, increased violence towards nurses, limited educational capacity in our schools of nursing, all combined with an increased demand for nursing. So this is a picture that I wish I could forget. Unfortunately, I just can't get it out of my mind. Our healthcare system at the institutional level, at the state level, and at the federal level, unfortunately, was not prepared for what happened when the COVID pandemic hit. We did not even have enough PPE to protect our physicians, our nurses, our other healthcare workers in the hospital. A high percentage of healthcare workers, be they physicians, be they nurses, or be they techs, died of COVID. I read in an article recently that one nurse in a New Jersey hospital in Newark, New Jersey, in her ICU, watched 11 of her nurse colleagues die. So that in combination with the tragedy of patients dying, their families saying goodbye, has really impacted the mental wellness of our nursing workforce. And it's not surprising with that background that between 2020 and 2021, a total of 1,000 RNs left the workforce across the nation. Bierhaus published that from his study. It was published in Health Affairs in 2022. And then just to make sure, National Council of State Boards of Nursing conducted a national stratified sample of almost 300,000 RNs across the country. They also confirmed that 100,000 RNs as a population estimate left the workforce during the pandemic. They also reported that 25% of current RN respondents plan to leave the workforce by 2027. In population estimate, this equals to 900,000 additional RNs planning to leave the workforce by 2027. 62% of the sample reported increased workloads and unsafe staffing levels, and about 50% reported symptoms of occupational burnout using items from the Maslach Burnout Inventory, which is the international standard. In 2023, I supervised a study in a sample of 156 New Jersey nurses, RNs, who practiced during the pandemic and are practicing now. 64% scored positive for occupational burnout using the entire Maslach Burnout Inventory. 51% screened positive for PTSD, and 42% are planning to leave their current job. There's also a large and longstanding empirical literature that quantifies the effects of poor RN staffing levels, unsupportive work environments on nurse burnout, job dissatisfaction, and plans to leave the job or plans to leave the nursing workforce. And again, in the Rutgers Library database, there are about 300 empirical studies that have quantified these relationships. With respect from an additional impact on the nursing workforce today is the rising violence that is being aimed at staff nurses, especially in hospitals. It's proposed that this is due to the low staffing levels that currently exist. When patients have to wait longer for their pain medications, when their call bell isn't answered, their families, the patients themselves become very irritated. Also, another factor is probably just the mental threats to mental wellness, I should say, that is not only present in the nursing workforce, but also in the general population. So while I don't naturally give much credence to studies that are conducted by researchers that work for unions, I think that this one is worth sharing. This survey was conducted in 2023. It was almost 1,000 respondents from 48 states, both aligned and non-aligned with the union. 26.3% reported that violence has increased a lot over the past year. Almost 68% reported that over the last year they were verbally threatened. 36% reported that over the last year they were slapped, punched, or kicked. 35% almost had objects thrown at them over the last year. 38% roughly were pinched or scratched, and 30% were spat on or deliberately exposed to body fluids. So what does the future hold for us? HRSA has been estimating a severe nursing shortage for the past 10 years. They are now adjusting those estimates, and they're saying that we will have a shortage of 350,000, 500,000 RNs in the year 2026. They estimate that the shortage will remain the same through 2031, and will not stabilize the supply versus the demand until 2035. And just to put this in a more local context, the Boston Globe reported in April 2024 that there were a total of over 5,000 vacant nursing positions in Massachusetts. Now, we don't know how they define nursing, whether they're talking about registered nurses or care techs included, but that is a lot of vacant positions. And last but not least, the American Association of Colleges of Nursing reports that last fall, 2023, over 55,000 qualified applicants to schools of nursing were turned away. This is actually a decrease because over the last 5 years, they've been reporting anywhere from 75,000 to 85,000 qualified applicants turned away from schools of nursing. And I'm embarrassed to tell you how many qualified applicants we turn away from Rutgers School of Nursing. Why? Lack of faculty, lack of clinical placements, lack of space. From my perspective, and I'm speaking only from myself, for myself as a dean who is expanding our admission cohorts, it is the lack of expansion investment funds. We cannot wait until students are standing outside our classroom doors to start hiring faculty, renovating space, and finding clinical placements. So what can we do? First of all, I'll say as a researcher who has been involved in this line of inquiry for the last 20 years, I advocate for state RN staffing legislation. I think that in our hospitals, we need embedded mental wellness counselors that are accessible to nurses during their work shift and near their units. I think we need to create and sustain supportive work environments where there is respect for nursing and respect for nurses. I think we need improved violence protection in our nation's hospitals and beyond. And I think we need state and federal aid for school expansions. So thank you very much for your attention, and thank you so much for inviting me to this important panel discussion.
Thank you so much for that presentation. Incredibly informative. I'm really excited to ask you more about all of those slides. Next, we will turn to Dr. Grant. Dr. Grant, whenever you're ready.
Well, I think it's like 60, but he's the chair. So, yeah. So basically, whatever, if it's Atari's or whatever, they just
okay. So thank you so very much to the Boston University School of Public Health for the opportunity to speak with you about some of the challenges facing the nursing profession, and that I think will continue to face us, that we will face for the very near future. I'd like to spend just a few minutes speaking from my point of view of what I think are some of the biggest challenges facing the profession since nursing probably became accepted as a true profession. I say true because nursing has developed over the centuries, and going from being viewed as a job that no one wanted to do. In fact, the first real nurses were monks who cared for the sick, the shut-ins, and the outcasts that society shunned, until gradually being taken upon by women and those who were blazing a trail for us, such as Florence Nightingale, Mary Mahoney, and Lillian Wall. So all of these ladies and those who worked with them and came after them have helped to forge nursing into the profession that it is today. Some of the challenges that I see the profession facing includes, but are not limited to, racism, workforce shortage, burnout, and legacy. And I will explain the term legacy a little bit later on in a few moments. When I entered the nursing profession in the 70s in North Carolina, I looked around and I didn't see many nurses who looked like me. Our profession did not reflect the diversity of the patients that we cared for. And I wanted to be a change agent to help change that. There's obviously has been no doubt in the ensuing years that considerable progress has been made with more opportunities for Black and Latinx and other minority Americans to enter into the profession. But I also saw that minority nurses still represented fewer than 1 in 5 of those in the RN nursing workforce. This is not and still is not reflective of the minority population as a whole, which is growing proportionally and will represent more than half of the total population in this country by mid-century. When I was elected president of the American Nurses Association, one of my top priorities was to promote efforts that would increase the diversity in nursing. I have long believed that health and healthcare professionals need to better reflect the diversity of the patients who we care for. And the more diverse the nursing profession is, the more effective we can be in helping our society address the growing racial disparities in healthcare and health outcomes. And it means that it would result in higher quality care for our patients. So as I began to work on this, a little bug called COVID-19 came along and derailed that plan, or so it thought. It turns out that COVID helped to turn attention to address these issues. In 2021, the American Nurses Association Board of Directors established the National Commission to Address Racism in Nursing. The commission is led by the American Nurses Association, the National Black Nurses Association, the National Association of Hispanic Nurses, and the National Coalition of Ethnic Minority Nurses. In addition, there are 39 other nursing organizations representing a broad spectrum of nursing practice, raciality, and ethnicity, and other diverse groups and regions across the country that serves to affiliate with the commission. Now, you may be saying, what does all this have to do with nursing workforce issues and et cetera? But I think it will come through fruition as I continue with the presentation. The commission's goal was to address racism. It is to address racism within the profession from 4 distinct areas: nursing education, clinical practice, nursing research, and policy. It also examines the issues of racism within nursing nationwide, focusing its impact on nurses, patients, communities, and the healthcare systems to motivate all nurses to confront individual and systemic racism. Now, since its founding, it did come up with a definition for racism, which is assault on the human spirit in the form of actions, biases, prejudices, and ideology of superiority based on race that perpetually cause moral suffering and physical harm of individuals and perpetuates some systemic injustices and inequities as well. Now, another challenge that I see facing the profession is that of nurse burnout and well-being. Additional surveys that were conducted by the American Nurses Foundation during the COVID pandemic revealed that nurses were suffering from significant burnout as a result of having to work mandatory overtime, the retirement of older nurses, and younger nurses who wanted to leave the bedside for more advanced positions, or because they felt the work was too hard, or they were seeking more lucrative paying positions as a travel nurse. The term quiet quitting became the phrase of the day, and how to address it became the challenge. We recognize that nurses must take care of themselves first before they can be expected to provide the care that their patients need. Employers must realize that measures should be put in place that will address physical and mental well-being of nurses and all members of the healthcare team. We cannot expect to continue to be asked to do more and more of our providers and provide opportunities and not provide opportunities for downtime. We know that the consequences of overworked, overstressed individuals, and that does not contribute to earning the trust and the confidence of the community and our ability to provide excellent care. So we must give ourselves permission to take care of ourselves before we expected to take care of others. The nursing workforce shortage itself is nothing new. It's been predicted over 25 years ago, but I would go so far as to say that we are in a crisis, not a shortage. And the reason that I use the word crisis is that there is an estimated need from one study that I saw of an additional 3 million registered nurses by 2030. That's just 6 years away. When we only graduate approximately 150 to 200,000 new graduates per year, that's not enough to replace those who are retiring, who left the bedside for other positions, or new expansions of healthcare facilities within the communities, which will also require additional nursing staff to help staff those facilities. We must look at new ways to recruit and retain nurses at the bedside. We must address the issues that are contributing to workforce shortages, such as violence in the workplace, also that may be caused by patients, family members, or our own nurse colleagues. We must also address the long hours and the low pay that also contributes to this shortage. And finally, nursing as a profession that is a profession that integrates innovation, technology, evidence-based practice, and critical thinking to ensure good health and outcomes for those that we care for. But we must also recognize that the image of nursing and what it takes to be a nurse is not fully recognized by the general public. Nursing has an image problem, and that the average Joe on the street has no idea what it takes to be a nurse. They know that you may work at a local hospital, but when you ask, do you know what a nurse does? There's a complex look on their face. A couple of ways to address the workforce issue may involve, one, developing a strong and diverse nursing workforce that is representative of the community served and be prepared to meet the growing health needs of the country. Another is to ensure that workplace culture that values the physical and psychological safety and well-being of nurses. And another is to equip nurses and the public to be strong advocates for nursing and healthcare improvements. And finally, as I made the comment earlier that there's a challenge to nursing's legacy. Nursing is a profession with a strong body of research, evidence-based practice, and scholarship. But one of my favorite saying is that if you're not at the table, you're on the menu. Our problem is not being at the table or not being heard when decisions about the profession are made by those who are not members of the nursing profession. Thank you for the opportunity to provide this opening comment, and I look forward to discussing more about this topic with my fellow colleagues.
Thank you so much. That was illuminating. I'm really excited to ask you more about all of that. Next, we will hear from Dr. Stanton. If you could join us on the screen. Look forward to your presentation.
Great, thank you. I'll just share screen. Okay. Thank you for having me. I can tell listening to the first two that I'm on this panel as the ridiculous optimist and the one who's, so you'll find mine very different, but complementary in terms of what we're all about, which is the health of the nation and the globe for some people. And where my head is how can we change the future of health, not just the nursing, but all of health, and trying to imagine that and then work backwards to what can we do now. And I think I represent the strain of thought that we may have enough nurses, but we have the wrong health system, the wrong medical system, really, and that it's reactive, it's acute care focused. You know, some of you will listen to what I'm going to say and say that's crazy, it's ridiculous, we can't achieve what you're talking about. I'm a big fan of high-hanging fruit. Low-hanging fruit anyone can do. It's the high-hanging fruit that creates new ways of thinking, new collaborations, new dreams that other people can attach their methods to. And so this is what I'm up to. And this may seem like a ridiculous thing to spend some of my 8 minutes on, but in 2010, some leaders in Baltimore said we should make the Baltimore Harbor swimmable, not just kayakable, but swimmable. And most people just really laughed at them. But that's an example of very high hanging fruit. And we've gone from this picture on the left that would just trash everywhere in the harbor, trash and chemicals, to now you can swim in it. And it was a conscious effort. Many people came together and said, oysters, we need oysters. There's now something like 30,000 oysters in the Baltimore Harbor. In the center, there's this Mr. and Mrs. Trash Wheel. There's 3 of them that are self-propelled and they go around picking up trash and people love them. They've got their own Instagram. And wetland, we've moved wetlands into the harbor. And the point is that if you just see the crisis in front of us sometimes it's hard to make a big idea that can change, can have giant impact. And so I'm really inspired by the harbor. So we all know the US healthcare system is broken. It's not really a healthcare system. It's a sick care reactive system. And just as one example, but you could pull out so many statistics. So we spend a higher percentage of our gross domestic product, that's like our overall economy, on medical care than any other OECD country, which is like the other, what people call developed countries. And that's almost double as what we spend. So Germany is our closest, and they spend about 12% of their GDP, and we spend about 20. And if that was purchasing health, I think we would probably think, well, that makes sense. 20% of our economy to make sure everyone's healthy and full of well-being. But we actually have the worst health outcomes of any of those countries. So this mismatch between what we're paying into it and the value we're getting is chronic. And it's something we've talked about for 30 years. And I think at first we thought, oh, well, if everyone has insurance, then we'll have better outcomes. And that's really important. But for example, in a city like Baltimore, 94% of the people have insurance now because we're a Medicaid expansion state and we've got good health exchanges, and still we have the same health inequities that we've had. So it's not just about insurance. It's about many things that we could go into for another talk. But so with my 8 minutes, I'm just going to go into the ideas. So this slide, it says disability, and but the point of this slide is that the green line on the top is the idea that kind of we all started mostly at the same early life point in terms of being born. If you told me you have a 2-year-old, I'd probably be able to guess that they're saying no a lot. They can walk and probably run. They're arguing with their siblings if they have them. But that we all start off kind of with a similar trajectory, but then over time that widens where some people have better health than others. And those are for structural reasons and reasons that have so much to do with social determinants of health and other things that we can go into in questions and answers. But that gap between the green and the orange, that is our opportunity. That is our opportunity to make everyone's life better. And there's nothing that says people need to have poor health outcomes. And so I don't know if, I guess I'm not seeing the chat anymore, but if people want to put into the chat, what are some of the elements you would think a perfect health system would look like? And I'll wait for just a moment, but I know we're busy people and I only have 8 minutes. And so I won't stay for too long on this, but just think in your own mind, one attribute of what a perfect health system would look like. And I thank you. I see that the chat things moving up in their numbers, and I won't read them right now, but I'll look back on them when we're done. Thank you for putting something in. So I would say equity, right? That that not just everyone has an equal chance, but that we have equitable healthcare. People, I think we would all want people to be free from suffering, to experience joy, to be able to participate equally in the opportunities of our society. And we would probably want it to cost less. And I'll really enjoy reading your comments about, probably you all have other good suggestions. So how do we get from here to there? Well, if we kind of begin with the end in mind, we want that kind of a health system. One thing that's already happening that we can go along the winds of change there's this shift towards value-based care, right? It's not the be all and end all. It's not going to solve everything. But the idea, just for those of you who haven't been following the shift, is that more and more providers and health systems and states are being reimbursed, not just for the care, you have a hospitalization, or you see a physician, or you see a nurse practitioner, or you have a procedure, but paying for health instead of health care, paying for the outcome that we all want to see. And so that's creating a difference from volume, trying to get as many patients in, to value. Maybe your practice sees fewer people a day, but you see them for longer and they walk away with more of what they need. And moving from paying for process to paying for outcomes, and moving from paying no attention to the social drivers of health to yes. When many of us were trained 10, 15, 20 years ago, we weren't trained we were trained to perhaps ask if someone had food or could pay for their rent, but we weren't trained to do something about it. That was the social worker's job or somebody else's job. But now it's much more incorporated in the health system. Just want to point you to the National Academy of Medicine investment in primary care. And you likely all know this, but it bears repeating. Primary care is the only form of healthcare that is associated on a population level with a population health impact. And this was co-chaired by a nurse. So what we are working on at Johns Hopkins, and we're doing it with the University of Maryland, Morgan State, and Coppin State, which are, so that's all the nursing schools in Baltimore, 2 HBCUs and 2 historically white institutions. We have taken inspiration from Costa Rica and to some extent Brazil and to some extent Cuba to have what geographic empanelment. So that means it's universal, it will be. And where you live is just for being a human, you have a nurse and a community health worker, and you have them over time. They're not students, and you have them whether you're uninsured or insured, and whichever insurance you have, so that each nurse will have 12 to 14 blocks who is their panel, and that's an RN and a community health worker. And the hospitals of the future are only going to be operating rooms, ERs, and ICUs. Everything else is going to happen out in the community. Hospital at home is already happening. Skilled nursing facility at home is already happening. And you all know people get sent home, the day or two after a heart attack. And our nursing education needs to change to focus on not just like traditional community health or public health, but also acute health in the community. Maryland is a perfect place to try this because we have a history of all the insurers working together to on hospitalizations. And so the next stage, we are betting, and we're standing up the system as fast as we can. The next stage of that will be on population health. We also think it could still solve the primary care shortage besides the nursing shortage, because you need a lot more nurses in a hospital because the ratio is different. You need 1 to 4 or 1 to 8, whereas in the community we'll have 1 to about 2 to 300. But we also think it's a great thing for stable careers for community health workers. They won't be going to grant. So I will stop there. And I look forward to questions. I just want to say, if anyone tells you you can't boil the ocean, I really disagree. You just have to start with small pots and get into increasingly bigger pots to test what you're doing.
There we go. So you're getting healthcare tips and how to boil the ocean all in one panel. Thank you so much for the presentation. Finally, we have Dr. Zank. When you're ready, if you want to join me on the screen, we look forward to your remarks.
Hi, good afternoon. Hold on, just let me share my screen again. Okay, great. Well, good afternoon to everyone. And thank you so much for inviting me to join you today. And what a great panel. So I've learned a lot and received motivation and inspiration from the panelists coming before me. So it's a pleasure to virtually join you all at Boston University School of Public Health to discuss the future of nursing. We are undoubtedly at a tipping point. Everything from climate change to gun violence is taking a toll on our nation's health and has put a huge amount of stress on an already fragile healthcare system as well as public health system. So needless to say, the next 10 years of nursing could go a lot of different ways, really as could the next 10 years of health and healthcare. And we, nurses, and anyone interested in affecting change need to be actively engaged in guiding that evolution. So I believe that the future of nursing is to be found in transformative action to achieve health equity, and that nurses are meant to lead these efforts that center health equity and address the major drivers of health and illness in our country. And I also believe that nursing is ready to take on this challenge. Much of the discussion in nursing right now, as Drs. Flynn and Ernest have discussed, is focused on very important workforce issues, especially for our colleagues working in hospitals. However, we also need to think about the context in which those issues reside. So health inequity, I would argue, is both a crisis for nursing and a crisis for nursing to address. The pressing issues we see in the nursing profession, shortages and burnout, don't exist in a vacuum. They are part of the health and healthcare landscape, and that landscape is rife with inequity. That's the reality of the day-to-day experiences of nurses. For example, we know that racism and unjust economic forces are two of the most important structural factors contributing to health inequity. Inequities are seen most critically, for example, in premature morbidity and mortality. Simply put, people are dying too soon and carrying a disproportionate burden of poor health because of racism and economic forces. Now, this fact alone should stop us all in our tracks. But we also see within the healthcare and public health systems the ripple effects. This includes significant financial considerations as we grapple with where and how to allocate scarce resources. And perhaps most importantly, the structural and social drivers are contributing to less effective care and worse outcomes. So it really isn't hard to see how that can contribute to challenges for nurses directly in the work environment. In order to create meaningful change for nurses and the individuals, families, and communities that nurses seek to serve, we need to widen the lens and prioritize health equity as our common goal. So achieving health equity means ensuring that all people have the opportunities and resources they need to achieve the highest level of health. I think everyone here understands this. And while it may seem simple, it was absolutely essential for nursing and INR and nursing science to boldly declare that we are prioritizing health equity. Relatedly, we need to ensure that our work encompasses all the drivers of health, including critically the social determinants of health, including those structural factors that shape the conditions of daily life. Too often, these ideas are viewed as outside the scope of nursing and biomedical research, or are not prioritized on par with those other areas of science. But NINR's position is distinctly different. We believe that health equity is a realistic and achievable goal, and that an additional emphasis on the social determinants of health complements what was already so special and unique about nursing research. Nurses and public health professionals know that the most important health-related activities often happen outside of hospital walls. Our holistic perspective and positioning within the health and healthcare landscape is unique and it's important. And combined with our values and the emphasis on relationships with individuals, families, and communities, nursing can provide essential leadership. Along with this, nurses can ensure that our whole picture of health is fully integrated into all biomedical health and research efforts. So that's what we are emphasizing at NINR. How do we take the invaluable work that nurses and nurse researchers have been doing for years and expand it even more? We think the answer is we focus on health equity and we prioritize the social determinants of health. So as director of NINR and really an absolute true believer in the power of nursing's perspective to bring about real change, I am especially focused on generating the evidence base that will make this future possible. Nursing should be at the forefront of research in this area, which includes bridging social determinants of health, healthcare, and public health. Taking on this leadership role is really consistent with where nursing has historically been and nursing strengths. That's one of the reasons we made health equity part of our mission statement at NINR. We've been working really hard to fund innovative research that addresses health equity. We're also committed to supporting emerging nurse scientists along their career path. We want the science and the researchers we support to have an impact on health for all. I also believe that the next 10 years in nursing will include, as Dr. Zanton suggested and others, a return to the roots of our profession by elevating and leveraging the role of nursing in communities. And it's going to take high quality, rigorous research to guide that shift. We want to see action informed by the advances in science and change, and as well as the changes of the needs of populations. Community engagement has emerged as incredibly important to all research efforts. And we at NINR believe that nurses are ideally suited to do this work and use this approach. In our strategic plan and our recent funding initiatives, we emphasize the importance of multi-level approaches that demonstrate cross-disciplinary and cross-sector collaboration and meaningful community partnerships. So to be clear, I am very optimistic about the future of nursing and nursing research, but there are real challenges that have been discussed, and I'm going to highlight one more. We have to address these if we are going to make the scientific advancements that I think nursing is capable of. We have unfortunately seen a dramatic decrease in the enrollment in PhD programs over the past 20 years in nursing. And this means we will not have the cadre of nurse scientists that we need to tackle the complex issues we see in health and healthcare. In 2021, the National Academies released the Future of Nursing 2020-2030 report and provided their perspective on the most important challenges for the nursing profession, as well as recommendations on strengthening nursing capacity and expertise. This report reiterated the critical need for more PhD-prepared nurses. And even more notably, they specifically say those nurses are charged with systematically building the evidence base around concepts and issues that connect the social determinants of health, health equity, and health status, as well as associated nursing interventions. And in our strategic plan, I am pleased to report aligns incredibly well with those recommendations. And we are committed to providing opportunities for both funding existing researchers and training new researchers to build that evidence base. So as I close, I want to emphasize this point. The future of nursing is bright, and it is closely tied to the future health of our nation. The persistence and magnitude of health inequities in the United States calls for an all-hands-on-deck approach that leverages the strengths of nursing and nursing research. And I want to personally invite all of you here to join us in this pursuit of innovative, nurse-driven, equity-centered solutions. It is really such an honor to be part of this conversation. Thanks again for inviting me.
Yeah,
Thank you so much, Dr. Zhang, and thank you for all of our speakers for their presentation. I'm eager to jump in here. There's so much to follow up on. Before we get started, if all of our presenters could turn on their microphones and videos back on for our discussion, and for the audience who's listening, get your questions ready. We'll have about 20 minutes at the end of our program to get to your questions, which you can submit using the Zoom Q&A function at the bottom of the screen. Note that that's different from the chat function. So if you want me to see your questions, make sure you put them in the Q&A function. Just to start, I mean, listening to all of these presentations, I'm struck by the scope of the challenge that is before us. I mean, it's burnout and staffing challenges are historic. COVID has escalated these issues, and they existed in the past nationally, and especially in Massachusetts, where, you know, I have a focus. There's not much diversity in nursing. And while one might expect that a solution is to increase the pipeline of trainees, hurdles exist there too. So I wanted to start, Dr. Flynn, with you to say, you know, given the challenges, given the scope of these issues, where do we start? What is the thing we do first? Or maybe there are many things we can do simultaneously.
Yeah, thank you, Jessica. Again, you know, at the root of the problem it is unsafe staffing levels. Understandably, we're short of nurses, or we're short of nurses who choose to practice, however you look at it. So unsafe staffing levels contribute to burnout, contribute to nurses' job dissatisfaction and their intentions to leave their job and their actual leaving their job. I am in favor of safe staffing legislation. I think nurses need to feel comfortable that when they are employed, whether it's in a hospital setting or a non-acute care setting, that they will be in an environment where they can provide the quality of care that they were taught to provide. So I think that has to be fundamental. We are all working on increasing our the pipeline. We are at Rutgers are doubling our admission cohorts over the next 3 years. We have already started. I chair the Big Ten Deans of Schools of Nursing. About half of them, which is now at the Big 16 or whatever, the Big 14, about half of them are also doubling their admission cohorts. But we don't want to feel like we're leading the lambs to slaughter. So, I always tell my colleagues in acute care settings and non-acute care settings, we educate them and we educate them very well. And in fact, 60% of our student body across degree programs from undergraduate through PhD are students of color, and they're well educated. But it's up to you guys. You're going to have to help us. You're going to have to help retain them. So we're not going to achieve health equity if we have a severe nursing crisis.
And Dr. Grant, we talked about burnout. You mentioned it in your remarks, but so much of the onus for that is often placed on the workers. But the solutions are beyond them. I mean, increased staffing and support staff are solutions that the administrators, that executives have to make. And so how can we incentivize health system executives and the larger organization to prioritize these problems in a way that can be challenging financially, in particular in this economic climate?
That's a really great question. And I think it boils down to healthcare administrators actually actively listening to what it is that the nurses at the bedside are saying that they need or that they want, or what is going to keep them there. When I was president of ANA, one of the things that I encouraged not only chief nursing officers, but also the chief financial officers of healthcare facilities to shadow a nurse for a week, not a day, but a week. And the reason that they needed to do that was they needed to have the experience of what it was like to work 12 hours without the possibility of going to the bathroom or, maybe getting a good drink of water or something like that. And they would understand. And I also would challenge nursing or nurses to begin to look at when they, call up for extra help and they told that, are told that we don't have anyone to send you. It becomes part of a pattern because they suck it up and, begin to, again, distribute the patients out more. And then when the next shift comes on and they say, we still need more nursing, and you get challenged with, well, the first shift did it, why can't you? And it sort of becomes, a game of acceptance, if you will, or an expectation that we're going to do that. We need to change those expectations and say, no, we do need to get, and listening with what Dr. Flynn has said, no, we need to have those numbers in place so that we can ensure that, correct care and proper care is being done. So there's a way to, begin to address that. But I think those in administrative positions need to be able to understand and actively listen to what it is that is going on in the culture, in the environment, and work with nurses to begin to change that.
Mm. And Dr. Zenk, how do we ensure that diversity is a cornerstone of a longer term solution, given that the challenge is systemic and larger than individual programs? How is it a core component of solving this challenge over the long term?
Yeah, diversity in nursing, you know, as Dr. Grant has really nicely laid out, is essential to address the needs of the population. And so in all aspects of nursing, and from my perspective, including in the nursing research workforce, we have to ensure diversity. It's absolutely critical for nursing to be effective and for us to be effective in improving the nation's health. So it has to be a focus for all of us. It is in nursing research, and it is, I think, I'm really proud to say, increasingly a priority across our discipline.
Dr. Zanton, what are the ramifications to not finding solutions? I mean, to many of these problems rapidly. I mean, the shortages are already having a financial effect on health systems. Is that just the start? Like, what do you expect to see?
So, well, you know, I think many of the speakers have talked about the vicious cycle of if there aren't enough nurses, then the nurses there are more likely to leave. And then that can be worse. And then, of course, if we're not well staffed in all our areas of health, then it costs more because, right, so the earlier someone can get seen for something, the cheaper it is, and of course, the better it is for their life. I would say that, you know, if you talk to nurses who are doing hospital at home models, they are usually ICU nurses who are doing hospital work at home of people, and they're very happy and they love it. And in some of the statistics we're talking about, they would be called and left the bedside, like they've left the bedside. And I just want to put another point of view up here that some nurses are actually leaving the profession, although we never say a lawyer is not a lawyer, like we are always nurses. But some people are doing their same work out in the community and they're not being counted in these kind of hospital views. So I think it's really important to be thinking holistically from public health to individual community health to individual acute, you know, all the way to the hospitals. And partly because the hospitals are dramatic places where people have their worst days, you know, and it's where the emergencies happen, it gets a lot more coverage. But I think we need a broader, more holistic view of what do nurses do and where do they do it, and that the future needs to entail a look across the whole spectrum, including research.
Dr. Flynn, you mentioned in your remarks, like just a staggering number of nurses who are leaving the workforce in the coming years. And so I'm curious from your perspective, what the runway is that we have to come up with some solutions to bring more people into the workforce, to start to fundamentally address these problems. We talked about this cycle. What will it mean if we don't make that kind of progress in the time that you think we have?
Yeah, it's a really good question, Jessica. And HRSA does project that the shortage will continue until I think it was 2036. So, you know, even in the best case scenario, it's going to be with us for a while. I do believe that we have to look at both sides of the pipeline. Schools of nursing need to increase their admission capacity. We're able to do that because we have some investment funding. So that is something that states as well as the federal level needs to consider. But the other side of that is the retention issue. You know, we can produce them, but they need to retain them, right? And so I think there is, again, a whole body of research that quantifies what a supportive nursing practice environment is. What are the characteristics of it? And that is definitely a key to retention. And as an old public health, community health nurse myself, I totally understand the need to have nurses in dialysis centers and Medicare certified home health agencies and public health agencies and skilled nursing facilities. But all of the quantitative research that I talked about has been replicated in those settings, some of it by myself, by me. And those core values, what nurses look for in the workplace, transcend setting. And so this is something that employers, regardless of whether it's hospitals or community-based agencies, are gonna need to take seriously.
And
Dr.
Jessica, can I
Grant,
make one more related
please.
point?
Yes.
In the chat, somebody asked, and I think it's relevant to all of us, about the NCLEX, which, Jessica, if you don't know, is the licensing exam that people take when they're after they graduated before they can practice. And I was at the National Council of State Boards of Nursing last week in Chicago. And I asked them about the question that the NCLEX is so focused on acute care. And then that means that nursing schools teach towards acute care because everyone wants their students to be able to pass this very important licensing exam. And the answer that they said, which maybe everyone else on the call knows, but I did not, was that it's focused on the skills you will need in your first year of nursing. And when they do surveys, they find that most people go into these medical or surgical floors their first year of nursing. And in fact, many people will have gotten that advice. You need to do 1 year, no matter what you want to do else, you need, but the more we have people who go straight into community jobs, and the more we honor that as part of our education, the more the NCLEX will change to reflect community health. And then all the nursing schools can teach towards that test instead of teaching towards this acute care focused test. So it's kind of a problem that we're all in, but as we start to change it, the NCLEX should change as well.
Yeah, it's very much a chicken and the egg problem, it seems. But Dr. Grant, speaking of retention in particular, with a shortage of nurses in this moment, I mean, we can work towards future solutions. We can try to solve these problems down the line. And forgive me if the newsroom is a bit loud here in the background. But hospitals have at points, in order to deal with this present problem, have not allowed some nurses to take time off, which in many ways exacerbates some of the burnout problems. And so how do health systems deal with the present challenge on the ground? Patients will keep arriving. There are not enough nurses right now. And how do we keep from exacerbating this problem over the long term while recognizing the needs of the present moment?
That's a really great question. And I think what a lot of healthcare systems have done, obviously, up until, what was it, about a month, I think, ago, that the national emergency was, surrounding COVID was finally lifted. So that did away with the mandatory overtime that, hospitals were able to apply to nurses. But again, I think it still comes down to the fact of, recognizing that you can't have staff who are suffering both mentally and physically from just exhaustion, of having worked overtime. That results in, as we all know, in a lot of patient care issues, looking at, medication errors and, all other types of errors and things like that as well. So it creates an unsafe environment in which to work. So healthcare institutions, what they need to do is to figure out some way to be able to allow for that, the time off that nurses need, some system of checks and balances as well, and to ensure that still that the staffing needs are covered. And obviously it's going to result in the need to hire more nurses, and make the job more attractive. And well, one of the things maybe they need to look at is look at the units where there is, high retention of staff. What is it about that unit that makes people want to work there? That makes, nursing staff want to stay with that particular nurse manager or nursing supervisor, and perhaps implement that, throughout the rest of the institution. There's ways that we can, look at it and address these issues, but it's a matter of really taking that concerted effort to sit down and really draw things out and get a good, clear picture from that perspective.
I also, Dr. Zank, was wondering if you see this solution as needing to be broader than just health systems, both individually, but also collectively, in order to, particularly dealing with social determinants of health. It's such a foundational challenge. Do public entities and governments have to be a partner in resolving these things in order to move the ball forward? Like, while we don't typically think of these things as the onus of healthcare systems, they are increasingly, but they can't do it by themselves. And so how do you view that broader partnership and relationship?
Yeah, yeah, healthcare is certainly important, but it's only one of the drivers of health, right? The determinants of health are much broader than that. And we know structural and social factors are foundational and major drivers of population health and the health inequities we see. So nursing has an important voice as well as role to play in the healthcare system, but as well as much broader than that in addressing the social determinants of health. And that involves working across sectors, and that involves research and practice that engages with policy and policymakers. And so nursing, I think one of our strengths is the breadth that we have in terms of our knowledge, and thus the roles that we can play, the many places that we can engage to improve the health of the public. Healthcare is part of that, but it's much broader than that. It's the community and beyond.
Dr. Zanton, you mentioned the exam, the potential shift of training down the line. How else do we need to shift training as hospital care shifts and changes?
That's a great question. Well, I think many of us at nursing schools are used to checking in with our clinical partners. As you know, they're some of our stakeholders. Sometimes they're on our board, sometimes they are on our faculty. But when we say that, we often are checking in with the hospitals that are near us, which is critically important. We always need to be there and, educating students who want to work in hospitals. But I think we don't as routinely check in with the school system and what's going on with school nurses and with the jails and the healthcare for the homeless where we are and all the other places that our students may end up practicing. And so I think we kind of coordinate and think through our education in general. And this is a big overstatement, perhaps, of the clinical partners that maybe we started off with when we worked with. And I think one of the questions in the chat was, how can people go into community because it pays so little? We, as a school, along with Morgan State and Coppin State, two HBCUs in Baltimore, stepped up when the Baltimore City school system asked, can you provide some school nurses, that they had lost school nurses during COVID because they closed the schools. And then when they came back, they didn't have. And so we said, yes, if we can pay them enough. And so we agreed with the Baltimore school system. We're paying a market rate that they would get in an acute care setting. And we hired people like that. I mean, it was almost instant. People love doing school nursing if it pays enough. But usually people in the community earn less than people in the hospitals, which doesn't make sense because you're more independent, you're more on your own, you're more, these jobs can be hard. Our school nurses are seeing 40 patients a day. But they love it, and it's a great partnership with the school system. So that's a long answer to your important question that, to look at the future of education, we've got to be thinking more broadly about the health of our communities and the health of our nation, and who are we educating for.
Thank you so much. Well, I'm going to get to some of these audience questions. First of all, compliments to the audience. You guys are a lively bunch. I have never seen so much interaction. Maybe I'm just not attending enough public school of health webinars. Shame on me. So, there are a lot. We're not going to get to all of them, but we're going to try. Starting with this first. So, Dr. Flynn, someone asked if these studies you mentioned mostly focus on nurses working in the hospital setting, or do they include home health agency and case management nurses who directly work in the community?
You mean the shortage, or do you mean the drivers of this shortage?
Whichever one you would, they just said these studies. So
these studies, right, exactly. As I had mentioned, I was among those that extended this line of inquiry into non-acute settings, including certified Medicare, home health, nursing homes, outpatient dialysis centers, and the like. And yes, and I also extended it to study these drivers among international nurses and things like a supportive work environment, which means, and there are several pillars to that you have a nurse manager who is supportive and works with you, that you have the respect of the physicians as your colleagues, that you have the respect of the organization's administration and they listen to your concerns, that there's opportunity for advancement. These are the pillars of a supportive practice environment, and that the staffing, whether it's home health or whether it's acute or whether it's dialysis or whether it's a skilled nursing facility, is a safe staffing level where nurses can deliver the care that they've been taught to deliver. So yes, these factors extend across settings, and that is evidence-based.
Thank you so much. Someone else asked, as a nurse, what can I do to help advocate for improvements in working conditions? I don't know if this question stands out to any of you in particular, or I can choose someone to answer. Dr. Zanton, what do you think of this?
So I've never once worked in a hospital. I've worked at all with migrant farm workers, and I'm assuming this is improvements in working conditions is about hospitals. So I would actually turf that to Dr. Flynn, who has spent more, and Dr. Grant. But I do think that banding together and having a collective voice is important.
Dr.
Yeah,
Grant, your thoughts, or Dr. Flynn, please.
Now, go ahead, Dr. Grant.
Go ahead, Dr. Flynn. I'll follow up with you.
Yeah. While I'm not necessarily a fan of collective bargaining, I'm not necessarily against it either. It's a fine line sometimes that we must adhere to, but letting your voice be known. Right now, nurses are voting with their feet, and that's not necessarily good for the public. It doesn't necessarily enhance health equity, obviously, and it's not good with respect to patient health outcomes. So rather than perhaps voting with your feet, let's talk about letting your voice be heard in multiple ways, and particularly engaging the public, as someone has already mentioned. 4 years ago, 5 years ago, nurses were heroes. Now they're becoming victims of violence. That's a pretty quick turnaround. So let's work to engage the public and help them to understand what we do and what we contribute.
I think also in addition to what Dr. Flynn has said, a lot of hospitals, they have a nursing governance council, which also helps to set policies regarding staffing. But the other thing too, agree very much with getting the public involved also, to be on your side, to advocate for, better staffing. And also, you as a nurse should become more politically savvy and, realize that it is the policymakers, the politicians, both at the state level and the national level, who make decisions that will affect your ability to practice, as a nurse. And so I think, meeting with them and explaining to them, or even joining their team and maybe volunteering to be their health liaison, because a lot of times, a lot of politicians, the information that they get is information that is fed to them by a lobbyist who obviously has their own special interest at play. But I think they need to understand the consequences of that vote, be it a good or a bad consequence. You as the nurse, speaking up. So going to them, telling them that you are a constituent of theirs, or that you are in the community with which, where a piece of legislation that they may be considering is going to be effective. And also letting them know that you are a registered nurse and that you vote. That's one way to get nursing's, voice out there. And of course, joining your professional nursing associations as well, and whatever legislative activities that they may have going. It's another good way to become involved and to help change working conditions from that perspective.
I know we have so many audience questions to get to. I can't help myself, though, as a journalist, of asking one of my own to follow up on this, because we didn't really talk yet about workplace violence. A lot of hospitals have instituted codes of conduct for patients. to combat workplace violence. And I'm curious if that is enough in your minds, or perhaps it's a model for other health systems. How do you view that particular solution?
I will speak first to that. I think having that there, as I mentioned, a lot of times institutions will have the policies, but sometimes when the incident happens and the person with whom the incident has occurred begins to follow the policy, sometimes they're discouraged from doing that. And what you're doing is you're sending a mixed message to the individuals. Initially you're saying the policy's there because we love and respect you and want to protect you, but then there's no follow through, or they're discouraged from implementing the steps within the policy. So you can't have it both ways. I mean, you really do need to say that if this policy is violated, then obviously steps will be taken to either whatever needs to be done for the perpetrator. But to have it on the books and not implement it is not a good thing, because you're really sending out the mixed messages, and that's something that we definitely want to get addressed. So that's my opinion from that. I don't know if the other colleagues have something a little bit different, but I'd love to hear what they may have to say as well.
Yeah, good. Can you hear me?
Thank you so much. Moving on to some other audience questions here. Dr. Zank, a person asked that given that there's been an emphasis on physical assessment in nursing school, what are your thoughts on nursing curriculum shifting to also highlight mental health and education and strategies to care for those with developmental, cognitive, and physical disabilities?
Yeah, thank you for that question. I might punt this one to our dean of a school of nursing, but one of the things I take away from that question is nursing does need to be responsive to the needs of the population, and that includes all individuals and all populations. And so I think that's absolutely critical that we're preparing nurses to help and work with all of those populations. And so the curriculum does need to reflect that, as well as, and I think I would be interested in Sarah's perspective on this. I think nursing has always recognized the importance of mental health and a really broad perspective of what it means to be healthy. And I think our curriculum has been successful in that, but I'd be curious about her perspective too.
Yeah, I'll just jump in and say I agree with everything Dr. Zank said, but I just, it's been in the last 20 years or so that, the textbooks and the teaching has gone from like, here's your predominant person, and they're always white and able-bodied, and other ways in which someone might think of them as sort of the general person. And then there's this little text box of like, oh, if you're Black, you have hypertension and this terrible thing and this terrible thing. Or so, and that it's just been like a big shift in nursing to try to change the textbooks and the lectures and the emphasis that to think about all the intersections that people may have, and that there's not a standard person, and then every possible deviation off is a different kind of person, and to see people really holistic. That's part of why it's so important to have really diverse nursing faculty and nurses, and to be thinking about all our learners as whole people as well. So I think, it's, and so that includes people's mental health and all of their strength. I mean, I think part of what the shift that we really need to make is not just to be thinking about people's needs and deficits, but what their strengths and their resources are. And that includes communities, and what the resources are of communities and families and of people. And that's part of why it's important to get people out in the community, because you see their whole self and you see the graduation pictures of their family members, and no matter what the neighborhood is like. So I think just in the spirit of the question, I think they're partly talking about this holistic view.
Another audience member mentions that, making the financial case for nurse value is critical because prevention saves money. But when it doesn't happen, that's hard to count. And so this person asks for any thoughts on how to develop the framework and financial literacy / business acumen for nurses to drive well-evidenced campaigns. I mean, some of this seems to speak to nurse research. Dr. Zank, I don't know if you wanted to take this question.
Could you reiterate the last part of it?
Sure. So this person asks, are there any thoughts on how to develop the framework and financial literacy and business acumen for nurses to drive well-evidenced campaigns?
Have something
Hmm.
that happened to them?
Um,
What was it? What am I thinking?
Yeah, that's a tough one. I think for me, what comes to mind is the breadth of interventions that are needed, and I think that there's much more that nursing can do in terms of developing different programs, systems, and models of care to address those range of factors. And I think we do need evidence in those areas. So I don't know if other colleagues have thoughts about that as well.
I think Linda talked about it a little bit in terms of nurse value. And when you have states with lower like I don't know, I don't mean to speak.
Yeah, like,
for
do we need to be educating nurses on how they quantify their own value within their, as an employee? Is that something that should be part of their education?
I think it should be, value-based care is something that there's quite a lot of literature about. I know that we do it at the Doctor of Nursing practice level. We're just starting to do it at the undergrad level. Basic economy, basic value determination. But there's so much in an undergraduate nursing curriculum that sometimes it's hard to find a slot for that. But I think it's very important, and we are starting to take that very seriously.
Dr. Grant, another person here mentions, and this has been spoken about in this conversation, that nurses are voting with their feet. They're going to travel and contract agencies. They are leaving the bedside, though those other jobs are critical and necessary, as Dr. Stanton pointed out. So this person asked, how can hospitals and administrators gain that trust back from their workforce? And can they? There's been this huge cultural shift because of the proliferation of traveling agencies and the need for them within the pandemic. What can be done to ensure the workforce, and also for the people coming into the workforce too, that the jobs that are there are fulfilling and will not leave them as husks of themselves?
That's a really great question, and we're sort of seeing a shift in that. Like at the height of the pandemic, what a lot of hospitals did or healthcare systems did was to create their own internal travel agency, so that they weren't paying out as much money to the travel agency as they were, and was saving, and that helped to retain some nurses. One of the things that I think is important is that, yeah, the healthcare facilities do need to look at, what are some attractive packages, if you will, that they could put together that would help to, keep and retain nurses, such as, if you're there for 6 months or a year or something like this, you get sort of a bonus, and a bonus could be different things to different people. For someone my age, a bonus could be, like an extra 2 weeks or 3 weeks of vacation. For someone who may be burdened with student debt, then it could mean that, okay, we'll pay you an extra $5,000 or $10,000 to help reduce your student debt. There's a lot of ways that institutions can look at creating a package, a retention package, if you will, that would make the workplace environment a much enjoyable place. You want to also have the nurses feel as if they belong there. That's one of the most important things as well. Feel that they enjoy coming to work, that they are part of the family and not just a number or a robot, but they have a say in policies and how things are done. So those are just a couple of quick examples off the top of my head that perhaps institutions are looking at, or maybe would like to consider as part of a retention package.
We probably have time for one more question, and I'm going to choose this one because I thought it was really interesting. Dr. Zanton, this person mentions that, you know, many nurses might not be educated in public health, potentially because of some kind of stigma associated with that work, that it is perceived as less than a nurse, reinforced by some administrations. And I'm curious your thoughts on the stigma within the classification of nursing jobs, if you perceive that to be there, and if so, how we combat that as we experience this broader shift away from hospital care.
It's a great question. And, you know, it exists on the medical side too, where the intensivists are, you know, kind of have more status than the pediatricians or the geriatricians. And it's true in nursing as well. And in fact, someone who works in the ER of a hospital, a local hospital nearby, said, when I was describing the neighborhood nursing, she said, wonder why anyone would want to do that. Maybe if they couldn't make it in the hospital. I just thought, wow, you know, it's just right there, the bias about roles. But I think, as I mentioned, that we're paying our school nurses the same they would pay inpatient. I think part of it starts with paying equally. And then it's really just getting people to shift to, right, different roles, take different skills, different temperaments. And if they can pay equally, I think that's a start towards addressing that bias.
Thank you so much. I think we maybe have more time. I'm going to ask as many questions as I can. Another person, Dr. Zank, mentioned, you know, where you get your strong optimism from. And so I'm going to shift that question a little bit and ask, you know, as we look to wrap up this conversation, if you could manifest for us. And we talked, and I think it was Dr. Zanton in your presentation, you mentioned the end goal, the kind of the vision, but you know, within the next 5 years, if you could manifest what achievable strides in solving some of these crises look like, what would that look like to you? What is achievable in the next 5 years as we think about the crux of this conversation and the scope of the challenges before us?
Yeah, I am optimistic. There are challenges to be sure, but I believe in the power and potential of nursing. I think we have a unique perspective. I think we have a very distinct positioning, ranging from acute care settings all the way through so many community settings. We have incredible potential and opportunity to make a tremendous difference in improving the public's health and reducing health inequities. And I don't think it's out of the question for nursing to step up, to contribute to solutions and make meaningful improvements in the health of patients, families, and communities. So I'm optimistic, and I think it's achievable. And I think nursing is well positioned to lead those efforts.
Thank you so much. Well, thank you all for taking the time to chat. I mean, we certainly have a scope of solutions in front of us after this conversation. And if people are paying attention, I think we can achieve those milestones that you've set out for us in the next 5 years. I see so many other questions we didn't get to in the chat function, so I'm sorry about that. This was a great, robust conversation. And before turning it back over to the Dean, I just wanted to thank you all for your time today, and thank you for letting me be part of the conversation as well. Dean, back to you.
Thank you, Jessica. And let me echo the gratitude to the panel and also to the audience. Jessica, at one point you made reference to such an engaged audience, and I thought it was a truly engaged audience with really interesting comments and really interesting questions. I want to thank the expert panelists for really interesting thoughts. You know, we host this within our public health conversation series, seeing the work of nursing as an essential part of the work in communities that public health tries to forge forward. And having these leaders guide us as you did today is really a privilege. So thank you. Thank you for the work you do. Thank you for being part of the conversation. And to everybody in the audience, thank you for engaging. Everybody have a good afternoon, a good